Good evening. I am Adedapo Odetoyinbo. I am from Emory Hospital. And for those who are wondering where that is, you just go up 85 through Border Patrol. Make sure you have your passport with you and you're in the promised land. Beautiful place, I promise you. So today I'm going to be talking to you about our roles as hospitalists, as consultants. This is something that has evolved over the period of time I have been a hospitalist, and I can tell you that a lot has changed, especially if you're in a community hospital like mine. So we will speak about the landscape. What really does this whole field look like? What types of consults and what has been described in the literature as the 10 commandments of consultation. We'll talk a little bit about what our hospitals say. What are we required to do and how we're expected to behave as consultants and when we consult. And then we'll go through a few potential pitfalls during the consultation process. For a lot of this material, I must tell you, I got a lot. The inspiration for this really came when I went through the SHM Learning Portal, and there's some great material there. So just a shout out for those who have not used that. There's a lot of material there. And then there are two seminal articles on consultation, one in 1983 and the other in 2007. So, landscape. So we have, as hospitalists, come to be regarded as a one-stop shop when it comes to consults. Gone are the days when that species called primary care physicians roamed the halls of our hospitals. And those days, the primary care physicians were called primarily to take care of their patients. And now, if you're not in a community hospital, this might not be fully appreciated, but it is so difficult to get several specialties to see patients. And frankly, when you have multiple questions you're trying to get addressed, it is so much easier, so much more efficient to get a hospitalist. And so we have really replaced many of the specialists when it comes to a community hospital setting in doing these consults. Also, there is the bit about us being just familiar with the hospital environment. A consult is more than just a medical question. A lot of the time it's about navigating the hospital and the complexities of the hospital. Now, clarity about rules of engagement is a lot of what we're going to be talking about today, and this is where the pitfalls could occur. So what are the types of consults? And I think some of the confusion we face is when we kind of put together all sorts of things and call them all consults. One is what we call curbsides, and then there is the traditionally defined consult, and there is co-management, which is really what most of us do most of the time. Now, a curbside is a curbside. You're called and you're asked about a patient. Your opinion is supposed to be rendered without really knowing the patient or going through their record. Your advice, if you're ever called for a curbside, is general and simple. You're really, and I think this goes without saying, you don't name a person you curbside in the medical record. Also, goes without saying you don't bill for a curbside. If there are more complex questions, once things begin to get more detailed, the recommendation is you request a formal consult. You really should not be given specific information when you have not assessed that patient. The traditional formal consult is really what, the way it's been defined and really is defined in most of our hospital bylaws, is a formal written request that addresses a specific question. And the expectation is, as a consultant, you're addressing that question, except there's something urgent that shows up as you assess the patient. The referring physician, however, continues to maintain responsibility for all the aspects of the patient's care. In a traditional consult, you actually, as a consultant, are not expected to put in orders. Although, again, as we evolve more into what I'm going to be talking about next, which is co-management, that's changing. The consultant's opinion, this is important, in a traditional consult is not really to be shared in detail with the patient. The opinion is not really for the patient, it is for your referring physician. And again, this is one of the areas where this differs from co-management. So, talking about co-management, that really is, especially for us hospitals in community hospitals, becoming the predominant mode of consultation. When I started this, it used to be that we had this whole thing going with orthopedic surgery about who admits the hip fracture and who doesn't, and all that has changed, at least in my hospital now. We pretty much admit the hip fractures, but the patients who have elective hip surgeries are now, we are being consulted, but truly what's been expected of us in these situations is co-management. The consultant in a co-management situation manages a defined aspect of the patient care. For us, it will be the medical management. That's the other term that's used. We put in orders, we communicate with patients and their families. That's the expectation. And in fact, often we are expected to also communicate with primary care physicians and other outpatient providers. And the responsibilities, of course, should be delineated according to your scope of expertise. The problem with this, though, is you don't know who's doing what. A lot of the time, there's 3-4 people who you're not sure who's responsible for what, and it's important to clearly negotiate this. So I'll go to what's been called the 10 Commandments from the landmark articles. The first is you determine the question. I think that, again, goes without saying. What really am I being called to do here? The urgency, there is a difference between a routine consult, which in many of our hospital bylaws is defined as something you do in 24 hours, and an urgent consult, which it's important that you know that these are time sensitive. You look for yourself. You're really not expected to, the expectation with the consult is that you go in and you dig the information. You be as brief as appropriate, meaning so once you have dug in, once you have gotten the information, you don't need to restate all of that information. It's in the record. And then be specific. Provide a contingency plan, meaning when you do a consult, you really want it to be clear what happens if A doesn't work, what do we do next? And make that clear up front. You negotiate your turf, meaning in this case, we're talking about orders. Teach with tact. I think, again, that goes without saying. Nobody really wants a lecture from you. But make sure that when you teach, you do it with tact. Talk is cheap and effective, meaning you call and speak to the referring physician, and then follow up. There is almost never an instance when a consult is expected to be done and you sign up the same day. That's very rare. Most of the time, there's the expectation that you're going to go beyond that. So I'll just skip through this part, which is really all of our hospitals have specific things. In fact, at Johns Creek specifically, if you do not get a consult when you should, that actually is a grounds for peer review. Potential issues, confusion about order entry, who's putting in the orders, how do you communicate? Is it text? Is it writing? Of course, we all recognize that with text, there's only so much that you should put in, especially HIPAA-sensitive information. Who does the med rec? Who does the discharge paperwork? All of these are things you negotiate, especially when you're doing co-management. Careful about fragmentation and duplication, and then, of course, be careful about multiplying consults. One consult should not lead to another that leads to the other without the consent of your referring physician. And with that, say thank you.